Dr. Garcia, welcome. It's a pleasure to welcome you to our drum circle here in Tambora Dialogues. Maria and I are super excited to share your story and your successes with our audience. And so we understand that you're the chief of cardiology and the co-director at the Montefiore Einstein Center for Heart and Vascular Care. And you're also a professor of medicine and radiology at Montefiore Einstein. And of particular importance for our listeners here in the Dominican Republic, and I think in the diaspora more generally, is that you graduated with a doctorate in medicine from the Universidad Nacional Pedro Enriquez Ureña, right here in Santo Domingo. So could you share with us what your journey towards your professional career was both here in the Dominican Republic and now in the United States?
Well, first of all, thank you, Erasma, and thank you, Maria, for the opportunity to speaking to you and reaching out to the community in my dear country of the Dominican Republic, where my heart is always present. I did attend all my education in the Dominican Republic until I finished medical school. In fact, I did all my elementary school, high school at La Salle College. And then I entered Universidad Nacional Pedro Enriquez Ureña. I came to the United States now a while ago to do my postgraduate training in internal medicine and cardiology. And I stay here in different positions at different hospitals, but always connected back home. In fact, my career took an orientation towards academics. So through my research, through my publications, I became a frequent attendant to the congresses in Santo Domingo. And of course, take the opportunity to visit family and friends, which I still have many of them back home.
Amazing. Thank you. Dr. Garcia, can you tell us a little bit, how did your studies here on the island prepare you for the rigorous career path that, lay ahead of you?
So the education back in the Dominican Republic, I thought was outstanding. In fact, when I look at many of the classmates that I have from my own year and from other years, back at where they are right now, many of them have achieved important positions throughout the United States and Europe. Many of them actually have returned to the Dominican Republic and practice there, but they all are top physicians. We, when I compare our education with the education that is typically received in the United States, I think that the experience that we have from volume of dealing with patients who are very sick and the opportunity to actually get involved hands-on in the management of patients is actually an advantage that we have by receiving our education abroad. It is perhaps our weakness, the education that we receive in basic science, in maybe basic research. So you will find that relatively we are less prepared in that area. But when it comes to the regular activities that we do during residency training in the medical specialties, and in the surgical specialties. We are all recognized for being ahead of the curve compared to the American graduates, to see that way.
That's so interesting. And so, what would you recommend? I know a few people, a few young folks that are probably going to be listening in. What would you recommend to some of these young people that are currently looking to, do their medical training in the United States? Do you encourage them to have the experience here and then do their post work in the United States like you did? Or do you just say, you know what, you can do it in the reverse? What would you recommend?
So I have to say that the postgraduate education, the education that doctors have to receive after they complete medical school, which is usually another 3 to 5, 6, or even 7 years,
Okay.
It's getting better and better back in Dominican Republic. I am very involved with SEDIMAT, which is a large multi-specialty hospital in Santo Domingo. And I've been doing that for the last 14 years, both taking a role in governance of the institution as a member of the board, but also as a person who attends and supervises residents there. And I've been witnessing how the residents, at least in the specialty of medicine and the subspecialty of cardiology, are very well trained, to the point that many of them, when they come here to rotate in my hospital here, they are actually teaching to our own fellows from here. So
That's
the
incredible.
education there has advanced quite a lot. Of course, there's always more technology and more access to information that you receive in the United States and many European countries. And that can be an advantage for many specialists, specialty training programs. So many physicians do have to travel to acquire those skills and to get that training that cannot be obtained there.
Mm.
If the students at the school are interested in moving to the United States for their training, I think what's important is to recognize what is the field that they're passionate about. That's, to me, is the most important thing. And sometimes you don't know that at the beginning, and you have to get exposed to different subspecialties to decide, I identify more with this physician or with this type of practice, and that's the way I want to continue. It is a difficult profession. It requires a lot of hours of dedication. I am here speaking to you, and I took off my coat and I put my jacket to be on camera. But after I'm done, I'm going to have to change to my coat again, and I still have to do some work on a Friday afternoon, and I have to round on Saturday and Sunday this week. And I've been doing this now for 35 years, and as a director of the program, I still do it. So I'm still very busy in both clinically, and of course, I am responsible for teaching my residents and my fellows. I do research, and I do have a lot of administrative responsibilities. So you're juggling a lot of both at the same time. And I think for most physicians, that's always the case. So it's a very demanding profession.
Mm-hmm.
So I think it's important that you have to really love the specialty that you get into it. I discourage people to go into a specialty because it's more profitable economically than another one. If you don't really have a passion for it, you're not going to be happy, no matter how much or how good is your compensation for that. But then if you are decided to come here, I think it's important that you prepare very well for the exams. Again, taking in mind that basic science is probably the weakest training that we receive at our medical schools there. We just don't have the infrastructure for basic molecular research. So we have to read a lot on the vacuum with our hands on. That makes it difficult. We don't have experience conducting basic research as much as the medical students get in the United States. Of the three components of the exam, that's probably the most difficult one. But I think my experience, those students that are dedicated and they also get, I guess, their education in English, so they can read in English and speak in English more fluently. They do well. They do well. They pass their exams.
Amazing. Thank you. Yeah, it requires definitely a big commitment to engage, to study, and then, a long-term commitment if this is the field that you want to spend the rest of your life in, right? So thank you for sharing that wonderful advice. Now, you've written several medical textbooks and more than, I believe, 160 peer-reviewed journal articles. And you recently also edited the book Multimodality Cardiovascular Imaging. And so you're basically internationally recognized as a leader in development and clinical advancement of cardiac diagnostic technology. And you're also, I hear, pioneering some work with CAT, coronary angiography, which has revolutionized the diagnosis of coronary artery disease. Can you share how you came to pioneer the use of this diagnostic technology?
Oh, that's great. It usually it's been at the right moment at the right place, and again, having an interest in solving a problem that at the time existed, and I was a young faculty member at the Cleveland Clinic when I got interested in this particular area, and I was collaborating with engineers that helped me to pursue some of the research ideas that I have. And one of them was to be able to evaluate the arteries of the heart without having to do an invasive procedure, without having to put a catheter inside the body. And the technology back then wasn't quite ready yet, but the people in the development, the imaging companies, they often rely on individuals like me and others that guide them into tailoring the technology to do something that may be useful. If they get the right guidance, they typically can modify what an equipment is able to do, and they can do it in many directions. So I collaborated with a group of physicists, mathematicians, biomedical engineers, and through some trial and error, we came up with some of the first devices that were able to do this procedure, the CT coronary angiogram. Since then, the technology has gotten better and better and better, and now that's a tool that is very well utilized all over the world. In fact, in the Dominican Republic, it's widely available in most major centers, and it's used, sometimes abused, but it certainly has made much easier to determine if someone who's having symptoms or who is at risk could have a blockage in a coronary artery. Doing the coronary angiogram invasively requires a preparation, is very expensive, the use of a room, a lot of personnel has to be involved. The equipment is not available everywhere. And in one day, in one piece of equipment, you can do maybe 4 or 5 studies, whereas with this device, you can do literally 30 or 40 on every device, and they're more widely available. It's less expensive and less preparation is needed. The patient can walk in and walk out.
Yeah. It's not very often that, one can say that, a medical tool is less expensive, right? That it's actually accessible to so many different people, and so that you can actually ensure better health as a result. So congratulations for that. Tell me, how do you have those quiet moments where you're like, yeah, I did that. I accomplished that, with my peers. Is there a moment of pride?
Oh, of course, yeah, it's absolutely great. I think, as I mentioned before, when you have in a schedule that can be unpredictable, you go to work and you know that you have to do a certain amount of things, but then your day is falling apart because patients that you did not know are getting sick and they're calling you and they're having problems that you have to manage. Or if you are in administration because there's some crisis that you have to deal with, certainly you derive that energy and that satisfaction to work longer and to tolerate some of these crises by either saving the life of a patient that otherwise was going to die, or improving their quality of life. And I tell you, that's probably the most important um, payment that we receive as physicians. So when you see someone that comes to you and you see their eyes glare and say, you remember me, you saved my life
Oh,
10 years ago, that is amazing, right? It doesn't happen every day, but it happens, and that keeps you going. But also when you do some advancement to science by research, and that can be used to improve the quality of medicine, that is also a great satisfaction. So absolutely, I get those moments, yeah.
wonderful. Thank you so much for sharing that. One of the things that I know that you're also really passionate about is, the prevalence of like heart issues and problems in the tri-state area, right? Especially in the Bronx, which, as we know, has an extremely high prevalence of heart disease,
Yeah.
risk factors related to heart disease, such as obesity and diabetes, hypertension. And so what are some of the ways that, you recommend when those patients come in and they have those risk factors? What are some of the things that you recommend that they do?
Mm. Yeah, so everybody has to be approaching a different way. That's been my experience through the years, right? There
That is
are,
a wise thing to say, right? Because I'm being honest, right? Because there's so many doctors that it's like it's very prescriptive, right? It's like, oh no, we're going to do the same thing because we've seen it work before. We're going to do it for everybody. But this approach is so different and so wonderful. So continue. Sorry for interrupting.
no, no, absolutely. I think, there are some things that unfortunately they come to you when you start to develop white hair. But you sit down with the first encounter with the patient, and the first thing you want to actually is have an understanding of this person's personality. What is their knowledge? What are their fears? His or her fears? What is that person willing to accept and not willing to accept? And you have to gain their trust. And sometimes you can get their trust on the first visit. Sometimes it may take several visits to do that. So I often tell my residents, yes, for this particular condition, there are 5 different drugs that are optimal. But if you take that patient that is skeptical about taking medication, and you tell them on day 1 you have to take 5 different pills on a schedule, they may end up taking none of them. So let's get to know them. Let's start with the most basic things, and little by little gain their trust, and go as far as you can um, uh, with the realization that not everybody will be able to take everything as written in the books. There are many challenges that we see. The same thing happens about the time that someone requires. There are patients who are very sick and they don't want to speak too much, or they want to spend too much time. There are other patients that are not sick, but they think they are, and they want to speak for a long time, and they want to be reassured many, many times that they're fine. And they take their time. You can't really, it's interesting because we try to be organized, and we schedule appointments, and we give everybody the same time in the calendar, but in reality it doesn't work that way.
Right.
Because sometimes we only need 10 minutes to do what we need to do, and sometimes we need an hour to get things done with someone, either because they're sick or because they need to have that communication very detailed to get your goals accomplished. So that's a little bit of the art of medicine, which is not in any textbook that I have written.
Right. No, exactly. So, Dr. Garcia, how has your Dominican identity informed the work that you're doing in the Bronx? It sounds like your approach sounds like, when I go visit my tia and she's like, ay, pero mija, ven, let's have a cafecito, let's have a chat before we get into anything other important matters, right? So it sounds like I hear some of that in what you're saying. So I'm wondering what other aspects of your Dominican identity factor into your work.
Yeah, well, I think is first of all, I have a incredible appreciation and love for the Dominican culture, the Dominican Republic. I grew up there. I learned. I am who I am because of what I learned over there, and I have a lot of wonderful memories. And I go there very often, not only for business, but for also for pleasure. And I think one of the reasons why I took the job that I took right now is because until this point, I had been dealing with a few Dominican patients that have the means to travel. I spent 12 years in Cleveland, and there are patients from the Dominican Republic who go to Cleveland Clinic to receive their care. But those are relatively a small group, a minority of people that have access to international insurance and have the economical means to go there. So yes, that's the way I started. But when I came here to Montefiore in the Bronx, when I interviewed 14 years ago for a job here, I really immediately on day one, I said, this is the job that I want, because I walked by the street and I saw the colmados here, el salón, el carrito de chimichurri, and all these things remind me of back home. And I say, I want to feel like I'm back home.
Yeah.
And I want to talk to the people that need somebody who understands their culture to receive their care. I have, at the time, there were many good doctors in my program. None of them, except one American doctor married to a Dominican woman who could speak Spanish. And I say to the people that were recruiting me, the chairman of the hospital and so forth, I say, you know what? I don't understand how all these doctors that you have here can talk to these patients, how they understand what they trying to say. And believe me, even today with translation apps and services that you get on the phone, the translator doesn't know Cibaeño.
That's right.
Or Puerto Riqueño, which can be also quite interesting and different. So you have to kind of have that background. So over time, I recruited a lot of people from different countries in Latin America. I have Dominicans, I have Argentinians, I have Colombians, I have Venezuelans, I have people from Central America that work in my faculty. So those are the front line, and those are the ones that deal with the majority of the patients here.
Wonderful. Thank you. Now, you shared before, kind of like what your week looks like, right? What the things are that you're actually doing, and how you have to, change your coat and do all these different things and manage residents, and manage also, the school. And so I'm curious, like, what is it that you're doing on your time off? Like, are you taking time off?
Yeah, I do. I have some hobbies. First of all, I try to give time to my family as much as possible. I have 3 children, different ages, and they all require different amount of attention, and different type of attention. So I try to do that first. I had an uncle who's still alive. He's going to be 100 years old in Santo Domingo, who had a furniture factory when I was growing up, and I worked with him during the summers, and I got an interest in woodworking. So whenever I have a chance, I try to do something with wood. I have some tools in my basement, and I can do a table. I can do some simple furniture, and that entertains and give me a distraction. I ride a bike once in a while. I go diving in Dominican Republic once in a while with some friends, scuba diving. So I try to try to get a little bit away from what I do every day.
Yeah.
During
Yeah.
vacation and weekends.
That's wonderful. That just reminds me that my husband bought my boys some wood because he too used to whittle wood when he was younger. And so my kids were like, "What? We don't get it." But now I'm going to say, "Look, Dr. Garcia does it. So you should think about doing it."
Sure.
Dr. Garcia, can you tell us a little bit more about like all of these advancements that are happening now in the field? What are some new technologies that you are particularly interested in that you believe could further advance like the field of cardiology?
Certainly we have the field of cardiology it's right now so subspecialized. So imagine that I am if I were in construction, I will be right now the general manager. That's what I kind of do in my position as the chief, right?
Yeah.
But then I have my team of electricians. Those are the people that deal with electrical problems of the heart. My team of plumbers, those are the people that deal with blocked arteries. My heart failure team, the people that do transplant and basically deal with replacing the heart when there's nothing else to do. My team of imagers, like me. So we have a difference of specialty within cardiology, right? I think one of the areas that everybody's interested in is in AI. It's how we can use AI to improve how we do things. And certainly there's AI that help us in interpreting images. So, I may have a lot of experience, but sometimes I may miss something that is evident in an image, and AI can help me identify, oh, by the way, you are looking for blocked in the artery, but look here in the lung, there is a lung nodule. Maybe this person is at risk of developing lung cancer. So that I think is important, and it's something that we're exploring more and more. We are looking at ways that we capture better the information that we get from patients. So we have now AI. We're working with an AI tool that basically listening to a conversation like the one that you are having, but instead will be between me and the patient, and basically writing a note in the medical record based on that conversation. So I don't forget everything you say. I don't misinterpret anything you say because everything is being captured. And I spend more time talking to you than typing or writing. So I think that's something that has a lot of potential. And I think another one that I'm passionate here in our hospital in the Bronx. By the way, we're not a hospital; we're a collection of hospitals. So right now, I'm speaking to you from the second largest one. This is the one that is next to the medical school. This is the Weiler division. The largest one is the Moses division, where I'm usually there on a typical day. So we have a lot of patients who are seeking to get an appointment, sometimes more than we can handle. And we need to figure out who needs to be seen more urgently than others. You know, we can't really give all of them the same appointment in line. They have to be different lines for the very sick, for the potential urgent issues, and for those that are, you know, not so urgent. So we're trying to work on AI that will allow the schedulers that are receiving the request for appointment to identify who needs to be seen more urgently than others, and try to prioritize people in that manner.
Yeah, no, so I was asking that the AI has the potential to help with triaging some patients, right?
Exactly. Yes. That's certainly something that we're exploring. So you know, AI I think is can be misused. It's very rough. You know, I use it, for example, to quickly find information that I may have an idea, but I may have not been up to date, or I don't remember very well. So rather than digging through mountains of journals or books, AI can guide me to a specific reference, like the same way that you do a Google search, right? But it's becoming more and more sophisticated. I still need my input, right? Because if the information is pulled out from a source that is not reliable, it may not be correct. So you need to know your field. I'm sorry, but a plumber cannot be a cardiologist, and a cardiologist cannot be a plumber.
Right. Yeah, of course. Yeah. I'm also wondering, you know, a lot of these issues are hereditary. So I'm wondering if over time, one of the things that AI can do is kind of track, you know, one generation to the next and help kind of help doctors like yourself make decisions about treatment earlier, or, you know, lifestyle decisions earlier, so that they don't necessarily repeat the same cycle of issues later on in life. Yeah, that would be interesting. Okay, and so, you know, you still have a very distinguished career. So I'm curious about like your legacy. Like what do you want your legacy to be? When you're thinking about writing your, you know, your autobiography, for example, like,
You know, I never thought about that.
oh, there you go. I just inspired you.
That's wonderful. Uh, I think my legacy are the trainees, the people that train year after year, and I hope to inspire on them. One is I guess, the ethical principles that they should adhere to, how to do the right thing always, how to treat patients the same way, no matter who they are, where they come from, and where, you know, I have several homeless patients that I see in my clinic. So they're hard to treat. They're very hard to treat, of course, but I treat them the same way in the same rooms that I treat the VIP.
Yeah.
So to me, there shouldn't be any difference with that. So I try to inspire my trainees to do that. I inspire them to be doing the research to find the most important and up-to-date information when they are in their practice and making decisions. I'm trying to improve the way that education is conducted. And some of the things that I've done in the last few years is be a member of some other organization that actually develop the exams for different disciplines. So I was, until not too long ago, the chair for the American Board of Internal Medicine Cardiology exam. So people that wanted to become a cardiologist had to take the exam nationally here that we developed. But we try those questions to be important, for example. So those are the type of legacy that I want to leave. Hope that my children do good.
Yeah. Thank you so much, Dr. Garcia. Really, it has been an incredible conversation. I really appreciate you sharing, your journey, your insights with us, and the real groundbreaking contributions that you've made to the field of cardiology. From what I've read about you and this conversation, I feel like your work has not only shaped how the field is diagnosing and treating heart disease, but also has really inspired so many. And we here in the Dominican Republic, if those that don't know you should be proud, and those that do know you are incredibly proud. So, thank you so much for all that you're doing.
My pleasure. And thank you again for inviting me, and good luck with your program. Hope it continues to be a success.
Thank you so much. To our listeners, we hope that today's discussion has deepened your understanding of the heart, both as a vital organ, but also as a symbol of resilience and innovation and care. Okay, familia, see you soon. Take care.